So you go back to the
COVID-2 now.
yeah.
COVID-2 was it?
Very, very,
Let's move it on our phone.
very similar.
Yeah, COVID.
It's one of the coronavirus. There are only 5 coronaviruses now, and SARS, MERS.
I think it came from a bat or a and or a snake.
Which ate the bat. They stuck, snakes stuck bats.
The person would be infected from eating the snake, said it.
The respiratory. Computer works now. Droplets from inhaling it.
And they used that snake for making
How do
jewelry.
you make a post? Yeah.
He said.
Yeah, it wasn't really a snake. It was something like a snake. They used to do it and ate the meat.
They eat, they slaughter every kind of animal that there is.
Yes. He speaks with clarity. He told us really what I want to know. There's no treatment. There may be, he was going to talk about vaccines later. There'll be a vaccine for it.
Huh.
Years developed.
Mm-hmm. But there's no medicine at this point.
Yeah, no medicine at this time.
He mentioned that remdesivir or remdesivir, but that doesn't work either.
He must just wince and sweat bullets when he hears the president proclaim.
Is the meeting going to restart? There's 173 people waiting.
We hope so. Fox News does not want to get him on the line.
You don't have just a minute.
Say that again. If you don't have a physical,
If you don't have a mask,
yeah, you need a seat. I'll just get it.
Are we able to hear now?
So did you dial in?
Yeah.
Right.
Yep.
All right, Lisa, can you confirm, can you hear us now?
Yes.
Yes, I
All
can.
right.
Are we on? Are we
All right,
functional?
we're on.
back. We're back? Yep. As I was saying, the SARS pandemic of 2003, I can't control this.
It takes a minute, but it'll come back.
Can I go ahead? Okay. The SARS pandemic of 2003, one of the most extraordinary features was a very high rate of infection of healthcare workers. That was unprecedented. We've never seen anything like that with any other human pathogen, even tuberculosis in tuberculosis sanatoria. And in the SARS epidemic, before they realized what was going on, that it was highly contagious, nearly half of all cases were in healthcare workers. And they got sick and they died. There was a 10% mortality of SARS. Once they realized its epidemiology and people started to adapt in terms of precautions, the risk dropped markedly, but it wasn't eliminated. COVID-19 has been very similar. There's been an extraordinarily high rate of infection of healthcare workers. Over 3,000 Chinese healthcare workers, 10,000 Italian healthcare workers, 14% of all cases in Italy are in healthcare workers. And thousands of European and over 300 healthcare providers have become infected. And about 1% of all healthcare workers who get infected die. Now, why is this? I think one reason is undiagnosed COVID-19 infection.
Really? So you
don't
different
have
about the question.
Yeah, exactly. Yeah.
Please mute your phone.
Mute your phone.
The second would be shortage of protective apparel, especially masks and gloves. Third is understaffing and exhaustion. People get careless. But another reason I think is very important, I've just written a paper on this, I'm submitting for publication tomorrow, is our policies for protecting healthcare workers, in my opinion, have not been adequate. Because, and I'll show you why shortly. This shows the masks. The masks that we use are probably the most important part of protection. This is a respiratory illness, and it causes pneumonia and fatal pneumonia. These are the 4 types of masks we deal with in clinical practice. There's or how to have flu when they're going to take them to x-ray or take them to the hospital to simply prevent a spatter of respiratory secretions if they cough or sneeze. That has very little filtration capacity for small particles. A surgical mask, a good quality surgical mask, provides a substantial element of protection against droplet nuclei. But it does not filter out tiny droplets in the range of half a micron or less that can get to the lung. N95 respirator masks do a pretty good job of that. And there are studies now from China showing that nurses that wore no masks had a very high rate of infection. Nurses that wore a surgical mask had about a 10% rate of infection. And in the one study that was published, no nurse who used N95s continuously got infected. PAPRs are positive airflow purifying machines that blow air through the inside of this hood and prevent any air from coming in from outside. These provide a very, very high level of protection. And when we intubate patients, when we bronchoscope patients, when we generate very high-risk aerosols, a PAPR is the safest direction to go. And that's where we use our PAPRs. Now, let me talk about the epidemiology of COVID-19. How do you get infected? It has been assumed by CDC and NIH that it's what's called droplet nuclei. This is the epidemiology of influenza. Tiny droplets, thousands are spattered out if you cough or sneeze, and you can inhale them, or they get into your mouth, you swallow them, or you get them on your clothing, and you then transfer it to your nose or mouth secondarily. Respiratory transmission over long distances beyond the patient's room is thought to be very rare, Because if you thought respiratory transmission posed a risk, everybody should be in a negative pressure room. Everybody should have an N95 mask, but that isn't what was recommended. I think there's considerable evidence that COVID-19 can be transmitted through the air over longer distances. And let me show it to you as the way I've put it in my paper. First of all, the SARS virus was shown to have the capacity for distant airborne spread. And since the SARS virus and COVID-2 are literally identical twins, they're biologically very closely related, it seems reasonable to assume that COVID-19 can also be transmitted by distant airborne spread. But that doesn't prove anything. Secondly of all, this is a cruise ship called the Diamond Princess. It's a Japanese cruise ship. It had 3,500 passengers on it. It was cruising off the coast of Japan. It had about 300 Americans on it. And they had a case of COVID-19 in very early February. They stopped, docked, they took off 3 or 4 passengers that were symptomatic, and they tested the whole group, and they found about 100, 150 passengers were positive, and they took them off. All the people who were left on, they would not let the other people off, for reasons that are unclear to me. They put them all in cabin quarantine on February 4. And these people were PCR negative on that day. Over the next 11 days till they let them off the ship, 300 more people became infected, although they never had direct face-to-face contact with the crew person or another person in another room. And when they let them off the ship, they went and they did sampling in rooms, and they found massive surface contamination rooms, including rooms of people who were not infected and people who were asymptomatic. And I think the only logical explanation is that there was transmission through the air supply. A cruise ship is no different than this building or any business building or most hospitals. You can't afford to have a separate air handling system for every room. So you have a master air handling system for a module. It might be the whole hospital, a small hospital. It might be 4 modules in a large hospital. In a cruise ship, they have 8 modules, 8 air handling systems. But they recirculate all the air because then they can heat it and cool it. And that recirculated air is a good way to transmit an airborne pathogen. During the outbreak of MDR, multi-drug resistant TB in New York City during the early AIDS epidemic in the mid and late 1980s, hundreds of patients got infected from infected AIDS patients who are highly contagious. Hundreds of healthcare workers converted their skin test, and they never got within 100 feet of an index case. It was all through the recirculation of air. And at that time, the federal government passed a law that all hospitals had to have 1 or 2 negative pressure isolation rooms. And every hospital, by law, is supposed to have at least 1, and most have more. I convinced our administration 35 years ago to put 2 negative pressure isolation rooms that we can control the airflow to be positive or negative pressure. We can code on every patient care unit. We got about 60. They didn't have that on this ship. And I think that there was a lot of airborne spread. Thirdly, there was a huge outbreak of COVID-19 in a large nursing home in Kirkland, Washington. And in this nursing home, they'd have had about 150 or so patients. 100 of them became infected. Something like 60 healthcare workers became infected over 10 days. That's a common source outbreak, and that has to be airborne. You couldn't have that many people. Person to person just couldn't happen with that many in 10 days. And I think it's highly likely there was airborne spread in that nursing home, because nursing homes don't have air control. They don't have negative pressure rooms. You can find SARS coronavirus 2 on distant surfaces in a patient's room, far more than 6 to 8 feet. You can find it in the air, and it's stable in the air for at least 5 hours. For all of these reasons, I'm convinced that although most transmission of COVID-2 occurs by droplet nuclei with close person-to-person contact, or contact can get it on your hands, you touch your nose, airborne can occur, and it's particularly of jeopardy to healthcare workers. Why? If you don't acknowledge it's respiratory, then a negative pressure room is not necessary. And until very recently, only in the last week or two, CDC and WHO did not acknowledge it, and they said you don't need a negative pressure room. So if you don't have a negative pressure room for a COVID-2 patient who's a super spreader, has got lots of virus, every time you open that door, it comes wafting out into the hall, you've taken your mask off, and you get infected. It also heavily contaminates the environment, and you cannot be careful enough when you take everything off at the end of the day.
So what does that do to the 6 feet criteria? Is that?
I don't think 6 feet criteria work for COVID-2. So, if COVID-19 can be spread by respiratory transmission, you not only need a single room, if possible, you'd like to put them in a negative pressure designated isolation room. A lot of hospitals can't achieve that. It's not realistic. You not only need gloves and a full sleeve gown when you go in the room, but I think that if you're going in the room of a COVID-19 patient, you want to have a mask on. If possible, it should be an N95 or a PAPR, especially if it's a high-risk procedure. You want to be extremely careful when you remove your apparel, and always do a vigorous hand hygiene after you've taken everything off. But here's the kicker. If COVID-19 patients are on the unit and you don't have negative pressure rooms, what protection do you have out in the hallway or in the conference room? The only protection you have is universal masking. That means you put your mask on in the morning. That's what I do. I put it on in the morning when I come to the hospital. I tape the edges with masking tape, and it stays on all day long. At the end of the day, if I've been doing COVID-19 care, I go down to a room where we have a shower. I carefully take everything off, throw it into a bag for the laundry. I'm wearing scrubs. I've got everything off. The last thing I take off, my mask very carefully, put it face down in the bag, and I get in the shower, and I totally shower off. I put on clean clothes, go home, and I then go into quarantine, separate from my wife. If you go to Asia, universal masking has been done routinely during flu season for 20 years. They showed during the SARS epidemic, universal masking in the hospital protected healthcare workers. There was benefit, measurable benefit. I think that hospitals that take care of COVID-19 patients should cohort their care. It should be a dedicated COVID-19 unit. They should not be take care of any other type of patient than COVID-19 patients. There's too much of a risk of cross-contamination to uninfected patients. Now, you don't have to go to this extreme, although this is being done in China and other places. It's not practical. You have to put it on, leave it on all day long, basically. You can't go on, put it on, take it off multiple times a day. This is good enough, and it probably provides a high level of protection. As long as you've got a good mask, a good head cover, you put on the gown before you go in the room. And interestingly, the studies during SARS found that the gown was far, far less important in protecting healthcare workers than the mask. The mask was the most important facet for protecting healthcare workers. If you go to Singapore, I consult for the Singaporean government. That is an extraordinary country. Their healthcare system is as good as any in the world. It's very cutting edge. They control SARS. When SARS came down the road and they realized how contagious it was, in 10 days, they built a dedicated SARS hospital with 60 negative pressure rooms and a cohort of nurses, docs, pharmacists, RTs that took care of nothing but those patients. They do a week on, a week home in quarantine, come back in a week on until SARS was gone. And it was very effective. They had no more infections of healthcare workers, and they controlled their outbreak. At university hospitals, about 15 years ago, was able to convince the administration to renovate one of our large medical units, it's a 26-bed unit, as an emerging pathogen surge capacity unit for emergent use. This shows this whole unit. It's got basically 4 wings, and one wing has got everything in to turn it into an ICU. Turn it into 2 hours. We can bring the ventilators in, everything, and take care of patients in a full ICU. This unit is sealed off from the rest of the hospital, has separate roofline exhaust. We now are putting patients in that unit. And we use cohorting of dedicated staff to minimize exposures of healthcare workers and other hospital patients to a virulent contagious pathogen. And it gives us 36 beds for patients. We have 2 other ICUs that we retrofitted negative pressure, so we could, in theory, ventilate up to 50 patients with COVID-19. And if everything hit the fan and it got worse, we could probably do 75 or 80.
And what's your census right now for those patients?
We've only got probably about a dozen. We're waiting for it all to hit. When it hits, it usually is very, very fast. One of my best friends in the critical care world is a senior critical care doc at the University of Minnesota. They were like us. They weren't seeing much, and just suddenly he called me up. He said it's hit. He had 10 admissions with COVID-19, and they were getting 1 every 2 hours once they started hitting. And it's just a measure of the huge amount of subclinical community infection that suddenly is becoming manifest. What about a vaccine? Well, let me tell you, coronaviruses have been of great interest for many years. And veterinary researchers have been working to develop coronavirus vaccines for animals for 20 years, unsuccessfully. There have been a half a dozen human coronavirus vaccine efforts during SARS 15 years ago. None of them was successful. There are 3 trials that have just started of a COVID-19 vaccine, and at least 19 other groups or companies have started work on a vaccine. But it's not going to be easy, especially since multiple animal vaccines have failed, as have experimental vaccines for SARS and MERS. The earliest we might have data that we have a vaccine that might work is probably 12 to 18 months. How else can we control COVID-19 in the population? Well, there are epidemiologic measures in the general population, home quarantining, which we're doing right now, with social distancing, closing schools, closing all athletic events, masking in public. Masking in public? We were told you can't do that. You shouldn't do it. It's a waste of money. It doesn't help, doesn't do any good. BS. There's considerable data that masking in public provides some element of protection against respiratory viruses. We've been sold a bill of goods. Now, I can understand that we didn't have enough masks, so it doesn't bother me as much because we desperately need masks for healthcare workers. But it was disingenuous. How can you tell an intelligent patient, say, masks don't do any good? And they say, why are you putting a mask on? Very good question. In hospitals, We talked about the measures to protect healthcare workers and other patients. Universal masking, I think, holds a great deal of hope. And I think that will very likely be recommended by CDC very shortly. It's being done, as I said, in Asian hospitals. Universal masking has been done for a long time. Did you know that if you're on the street in Hong Kong right now and you don't have a mask on, you can be arrested? It is a law that you are masked in public during the pandemic. Nursing homes have very limited options. The most important is restricting visitors. The best nursing home in Madison is Attic Angels. Unfortunately, Attic Angels is so expensive. It's for the beautiful people of Madison. You or me could probably never afford to go to Attic Angels, but it's a very well-run nursing home. I've had many patients there. They have a very stable staff. They pay their people well, and as a consequence, they really have excellent nurses, excellent nursing aides, clean as a whistle, very well-run. They totally closed down Attic Angels, nursing home, assisted living, apartments, almost 3 weeks ago. And if you leave, you won't come back in. The only people who are allowed in are service people and employees. And they're screened very, very carefully for fever or any signs or symptoms. And anybody who is COVID-19 positive will be out of there in a flash. And that's the best that a nursing home can do. Nursing homes are basically fodder for this virus. This virus spreads like wildfire through nursing homes. And after the Kirkland nursing home outbreak, this huge outbreak, 10 more nursing homes in Seattle have COVID-19. Nursing homes all over Europe are full of COVID-19, and it's killing patients like flies because it's a very frail, fragile population who are not going to do well with COVID-19. And you don't want it to get into the nursing home. You're going to test symptomatic residents, quickly isolate them and get them out if they're infected. Close monitoring of healthcare workers.
Dennis, how do you protect nursing homes from asymptomatic staff that are carrying it in?
You don't have any, and I'm going to come to that right now. I'm talking about testing as a control measure. This drives me nuts. I fought a battle and lost against HIV testing 30 years ago. They passed a law in Wisconsin that greatly restricted HIV testing when we tried to make the case that HIV testing was a powerful weapon to prevent spread. And I can remember I wrote letters to all the legislators, to the paper, and I can remember the governor saying, don't worry your little head about it. We'll take care of this law next year. It still hasn't been taken care of 30 years later. And HIV testing is one of the most powerful weapons we have. I wrote a paper in the New England Journal saying we need to do testing, and I got literally spit on. The chairman of the President's Commission on AIDS said that I was a racist, I was discriminatory because I was recommending wide-scale testing. I said it's the best hope for controlling spread. Now, quietly, 30 years later, CDC is pushing testing like mad as a weapon to control HIV. Well, the same thing has happened here with COVID-19. Our federal government, for very unclear reasons, did not want to do a lot of testing, and they did not develop and make available commercial PCRs. 15 companies had top-flight countries, had a PCR that they had field tested and worked, was ready to go a month ago, but they were not approved and not allowed to use it until very recently. So as a consequence, as recently as 2 or 3 weeks ago, Korea was doing 10 times as many tests a day as we had done during the entire pandemic. And even yet, in many areas of the country, you have to wait 2, 3, 4, 5, 6 days to get the results of testing. This is insane. This is a technology that we use for HIV testing and flu testing daily. It's a stat test for flu during the flu season. and we can't get testing done, and still tiered, you have to get approval to get testing done. This is insane. Testing would be very, very helpful to us. If we had same-day results of all symptomatic hospitalized patients, this would conserve precious apparel. We have burned up all of our masks and gowns and everything by isolating rule-outs who are negative. If we'd had the test result when we admitted them, which we should have had, we never would have had to waste all this material that we now wish we had. Same-day results of all symptomatic patients in a nursing home allows them to remove them from a nursing home if they're infected. Massive widespread testing of well persons to detect silent infection has been the cornerstone of control of pandemic Covid-19 throughout Asia, particularly in China, South Korea, Hong Kong, Singapore, and it has been very effective. Very effective. In these Asian countries, if you're positive, I don't care if you're asymptomatic or not, they don't say go home and lay low. They segregate you from the population. In China, they would put you in a big athletic stadium. They had thousands of cots lined up. They bring the food in. You didn't come up for 2 to 3 weeks, so you were no longer contagious. Removing infectious asymptomatic people from the population is a very effective way to control spread of COVID-19.
So how do you,
This is where we get to the concept of flattening the epidemic curve.
so who
Yes.
do you test in it? So when you say asymptomatic testing, is it anyone who walks into a grocery store, or
Anybody,
if you
in
want
other
it,
words,
just go get it?
If we could test every person in the population, and those who are positive would be segregated from those who are negative, that would immediately stop spread. Right off the bat, that would stop spread. The few people who were incubating and were false negatives would be identified and follow up. That would stop spread. Let me show you what's happened. Here's China. 80,000 cases. They controlled it in 1 month. 1 month. Here's South Korea. I believe their data. They started having a lot of cases. They did that. They did more testing than anybody in the world, drive-through testing, and they controlled their outbreak in about 1 month. The rest of the world is not doing that, and the rest of the world is swimming in COVID-19. And this simply shows us a little bit better. So what does the future hold? What have we learned? Well, the first thing is, I don't think we've learned very much. We were warned. We were very poorly prepared. We didn't have adequate protective apparel. We didn't have adequate ventilators for a pandemic. And in fact, the federal government closed down the pandemic preparation office 2 years ago. The CDC, which has been a superb institution, failed us terribly, just terribly. And the lack of testing allowed the virus to penetrate throughout the population, and we're now paying the price. We will very likely have a pandemic that will involve millions of people with infection, and we will have perhaps 250,000 deaths. I hope I'm wrong. Will there be subsequent phases of this virus? Will it come back in other years? Will it become endemic? I'm praying it's going to behave like SARS. SARS came with a burst and killed a lot of people, killed 800 people, 8,000 people rather, out of about 100,000 who were infected. And then it went away and never came back. And since this virus is so close to SARS virus biologically, my prayer is that what this virus will do, but we will only know when we see it. Because we are very early in the phase of our epidemic, here's us. we're very likely not going to be on the other side for at least another month or two because we don't segregate silent infected patients. In fact, what is our mantra? If you're asymptomatic and well, you don't need to be tested. Get out of here. We don't want to see it. I think that's a mistake. So there's a huge amount of research ongoing. The last time I counted, there's been over 2,000 papers published, studies, reviews, proposals in the literature. It's been extraordinary. There's been, in my memory, there's never been so much attention of the medical community focused on one disease. It's been all-consuming. But we're in the midst of a pandemic that's going to kill a lot of people and is going to have profound economic consequences. At the best, it'll trigger some recession, almost certainly. Hopefully, it won't trigger a full-blown depression with 30% unemployment. But I think the America of post-COVID-19 will be different than it was before the pandemic started. Thank you very much.
Thank you very much, Dr. Maki. And what we will do is please keep your phones muted, but go up to the chat box. Rich Bonger is monitoring, so if you have questions, please type those questions in, and then Rich will ask Dr. Maki the question.
So the first question, how often do you need to test people after the first negative result?
Can you repeat the question up there, Dennis?
The question is, how often do you
Rich,
need to
come on over here.
But there, it's picking up too, Dr. Schultz, over there.
First question is, how often do you need to test people after the first negative result?
If you have a very high suspicion of COVID-19 because of exposure or the clinical picture, I would retest them within 3 days. If I had a high suspicion. Yes.
So should the operating rooms, if you're injured?
Should operating rooms be testing patients?
What's that?
Are you asking, should operating rooms be testing patients?
Yeah.
We are. We are testing asymptomatic patients undergoing surgery at the present time. Our surgeons have demanded it, and we've accommodated that request.
And then are they using negative pressure rooms, positive pressure? Do you know how
operating rooms usually are closed rooms. They have a high rate. You don't need a negative pressure room if the person's negative.
Okay. What about a positive COVID
A
patient?
positive, they would go into a negative pressure room.
Okay.
The building and grounds people would have to set an operating room at negative pressure.
Okay.
Yep.
So would you do so should we be asymptomatic?
They would not do an asymptomatic person who did not have emergent surgery. I mean, if they had a perforation or necrotizing soft tissue infection, then they're going to get their operation in a negative pressure room. Anything else, you're going to wait till their infection clears. That's going to be about 2 to 3 weeks.
Okay.
What about returning healthcare workers who have been tested positive?
What about healthcare workers who are tested positive? That's a very good question. Many healthcare workers will be exposed. If we sent them all into home quarantine, we wouldn't have any healthcare workers left. So we allow exposed healthcare workers to work, but they mask universally. And at the first sign of symptoms, they withdraw from doing healthcare and they're tested. They go into home quarantine until we're confident they don't have infection. Infected healthcare workers, we would probably not have them work unless worse came to worse and we had no other options. And we would wait until they had cleared their infection.
Do you have plenty of COVID-19 tests down at UW?
Yes, we're doing hundreds of tests a day now.
And we're doing
something that we should have been doing a month to 6 weeks ago, and that is in-house testing. I could not understand why we couldn't get in-house testing when every hospital in the country can do in-house testing for flu. And we now are getting in-house testing, but we are still being restrictive on it. And they don't want us to test asymptomatic well people, which to me doesn't make much sense. but nonetheless, that's our policy.
So as testing hopefully becomes more available, should we be testing asymptomatic, well healthcare workers on a regular basis?
Will the day come that we routinely test healthcare workers? I think it could. It's not here yet, but we have a low threshold to test healthcare workers. I mean, if I this morning said I don't feel good and I'm scheduled to work this afternoon, I would immediately go to a drive-through and I would not show up for work till we had the results.
So another question from the panel. Can Dr. Maki comment on the balance of risks for surgical site infection with doing surgery under negative pressure for COVID-19 patients?
That's a good question. What is the impact of doing surgery in a negative pressure room? I don't think it'd be real high, only for the simple reason that usually operating room areas are pretty clean. And I think under the circumstances, the potential contamination is trivial to the likely contamination while you're doing the operation. You're doing it for perforation or necrotizing gallbladder or draining an abscess or something. And so I think that the risk is minor compared to the importance of doing the surgery.
Next question. Given that we are supposed to be testing, what are we supposed to do with the limited testing resources and the long turnaround times for results?
So 5 tests we can do a day at Prairie Clinic. How can we do that?
Yeah, that's pretty pitiful. It illustrates the magnitude of our problem. You can only do 5 tests a day in your clinic. That's pitiful.
Should we send them to your clinic?
If they want to drive to Madison and do drive-through, that's fine. But our testing people might turn them down if they don't feel enough risk. And so this simply illustrates the magnitude of the problem we have with not getting testing on command. We should have testing widely available. Whenever you want to test, you get a test. That just only makes sense. The fact that we're now in the 4th month of the pandemic, we still don't have that, to me, is shameful in this country.
Dr. Maki, one thing I saw in China when they were doing as the follow-up, all of the testing, then those residents were getting either a green card, a yellow card, or red to monitor and track. How often were they rechecking the green or yellow?
It's varied by hospital. Some hospitals were doing a lot of testing, others were not doing as much of healthcare workers. But when they realized how many healthcare workers are getting infected, they did a lot of testing as a rule. And we only test people right now if they're symptomatic.
Sure. And one initiative we are doing here in Sauk region is getting out into the public at least the cloth surgical masks to help with droplet. Do you feel that's effective?
I think that's effective. I think droplet protection is worthwhile. Absolutely. Now, N95 is not a surgical mask, but it'll probably put an element of protection. I think it's worthwhile doing.
So the homemade cloth ones are better than nothing?
Better than nothing, absolutely. Yep.
So next up, and we may have just covered this, do you recommend a surgical mask or N95 mask to preserve minimal N95 masks?
If you have very minimal N95 masks, I would save them for when you have a COVID patient who you're going to have to intubate. Do you have any PAPRs here?
Yes.
Yeah. Use PAPRs for intubation. Yeah, that's good. I use N95s mainly if I have ICU patients on the ventilator for an ICU room. That's what I save my N95s for. And I would save them if you, I don't think that under a best possible case, I don't think that small community hospitals should have to take care of complicated, ill COVID-19 patients. You don't have the resources, you don't have the environmental resources, you don't have the expertise with multiple specialists, and I think it'd be far better for them to be taking care of major centers. Our biggest problem is that major centers are getting filled up. I have an email from an emergency department doc at a community hospital outside of New Orleans. It's one of the most poignant emails I've ever read. And he said that my community hospital, 250 beds, we have 30 patients on a ventilator. I don't know we got that many ventilators. Then we have another 30 or 40 patients on the general medical ward. We can't transfer them because all the hospitals in New Orleans are full. They won't take our patients. He said, I wear a PAPR in the emergency department for my entire shift. And I sent my wife to stay with the in-laws. And when I do COVID care, I will be living in our lower level in our condo. And I've set up the airflow with a fan in the basement and a crack a window in the basement so there's a flow from top to bottom throughout. So I'll come home and sneak down to the lower level and we'll live down there for 2 weeks after a shift on the COVID unit because I don't want to develop asymptomatic infection and infect my wife only a month after open heart surgery. So,
Dr. Maki, is there any discussion at the state or in Madison about having a centralized or two centralized COVID hospitals, be it Meriter or Taft?
No, there's no discussion to my knowledge. The larger hospitals are expected to be able to deal with COVID. Meriter, St. Mary's, University, and VA are all prepared to deal with COVID. And they have resources to deal with COVID. They ought to be able to deal with COVID well. I think
Will they be filled up?
They may be filled up. If they get filled up, you may have to do COVID care. That's the point.
So should we make it a priority initially to try to get those COVID patients down there? Or
Right now, while we have beds, absolutely. I would, right now, I see no reason for a COVID patient sick enough to have to be hospitalized if we've got beds, rather than put them in your hospital.
Mm-hmm.
That's what I would recommend.
Is UW planning an HCQ/AZA study? And what type of patient?
Hydroxychloroquine study, azithromycin. Hydroxychloroquine and azithromycin has been shown to reduce the level of viremia. But there is no data that shows it brings clinical benefit. It's being given like water. We're giving it to patients. But there's no data to indicate that it's beneficial. I can live with it because I don't think it's terribly hazardous, but I'm so frustrated that we don't have a large multi-center trial that includes COVID, includes chloroquine or hydroxychloroquine, with or without it, so see if that has an impact clinically. The world of antiviral therapy is filled with drugs where it looked like this is going to be work great. It kills the virus in the test tube, and when they're tested clinically, they do nothing. Probably the best example is ribavirin for influenza, for RSV, and for a number of other infections. The only two infections that RSV has been that ribavirin has been shown to be effective for is Lassa fever in Africa and hepatitis C.
And what about
Stepping back from the hospital setting,
I'm sorry?
stepping back from the hospital setting, as a primary care provider and in a clinic setting.
Let me tell you what we're doing in our hospital.
Let me ask, yeah, just.
We are asking nurses and doctors to mask for all patient interactions, not just COVID-19, all patient interactions. I think that's good.
In terms of seeing patients, not seeing patients, seeing some types of patients, telling other types to wait 3 months to get seen, the workflow, can you just speak to primary care workflow and maybe some tips or things we should do or shouldn't be doing, worrying about, not worrying about?
Well, at this point in time, the patients you need to focus on are the patients who need to be seen short term, who've either got very complicated chronic problems that you see very regularly, or who have acute problems that need to be dealt with without delay. everybody else can wait, but you can handle a lot of things by telephone, and we're doing a lot of teleconsultation. Almost all of our outpatient clinic visits now are done by teleconference.
Somewhat related question, should universal masking include patients donning masks?
A COVID-19 patient, if a person is going to come in the room or they're going to be taken to x-ray, should mask. They should have a surgical mask on, or at minimum a spatter mask.
How about if they just come into our clinic?
Pardon?
When they come into the clinic, shouldn't they be
A
masked?
COVID-19?
Yes.
Oh, absolutely.
No.
Absolutely.
No.
They
Any
should do that.
patient.
Absolutely. Yeah.
Any patient
Any
coming
patient.
in, an obstetrical patient?
I think it's more important for any patient that the healthcare provider is masked. If the patient can be masked, that's ideal, but that may or may not be feasible.
So given what you know about supplies, is there enough supply for every patient who
That's
walks
my
in?
concern. My concern is supply. That's exactly right. I think it's essential that healthcare providers who are doing patient care and particularly doing COVID-19 care have adequate protective apparel. That's very high priority.
Did you have something?
Dr. McAuliffe?
So what has been found thus far about immunity for recovered patients and asymptomatic tests?
I'm sorry?
What has been found thus far about immunity for recovered patients and or asymptomatic test plus COVID-19 patients?
Yeah. The question is, if you get infected by COVID-19, are you immune from reinfection? We don't know that because it's too early, but I'd be very surprised if you weren't. This does not appear to be mutating like influenza, where I can get H3N2 this year, and I might not get it next year, but 2 or 3 years down the road, I can get it again. I think if you recover from COVID-19, I think it's highly, highly likely that you're going to be immune for a considerable period of time from reinfection.
So SARS and MERS, there was a
Yeah.
long-lasting...
Survivors have, I don't think there's been any documented reinfections in survivors.
Go ahead.
Is there a reliable test to see if an individual has had COVID-19 and recovered?
Is there a reliable test to see if somebody has had COVID-19, it wasn't detected, they've recovered? Yes. There is a serology that looks promising, but it's not commercially available yet. I'll be surprised if it's not available within another month.
Is there a regional plan for South Central Wisconsin? Can we expect to transfer critically ill patients from Sauk UW, or should we expect them locally?
I think that you can certainly expect to transfer them as long as we have beds. If the day comes that we're all overwhelmed in Madison, we have every ventilator is filled, every bed is filled, then we're going to say, sorry, we don't have anything we can do. But this brings us to something that they're having to do in New York, in Italy, Spain, other parts of the world where they're getting overwhelmed. They're having to make triage decisions. And the triage decision is, if I've only got one ventilator left, who gets it? Or I've got one ventilator left, but a patient comes in who's 92, has heart failure, and they probably would not survive even if I put them on a ventilator. We shouldn't put them on a ventilator. We've not had to make those decisions before, but we are making these decisions now, and they're correct decisions. What I really would like to see done, I'm writing a letter to the editor on this. I think that since there's already shortages of ventilators in certain areas, we should have already done this study. This study could have been done in 5 days. You'd get the data on the first 1,000 ventilated patients in this country. You'd go and review the records. What was their FiO2 when the decision was made they had to be ventilated? What was their FiO2? What was their age? What was their sex? What was their comorbidity? Did they have diabetes? Was it insulin dependent? Did they have hypertension? Did they have heart failure? Did they have cancer? Were they on chemotherapy? Were they on immunosuppressive therapy? And with 1,000 patients, you could develop a multivariable model and make a score the likelihood of surviving if you're intubated and ventilated for COVID-19. And if you got above a certain score, nobody had survived. Then the appropriate thing to do is individuals that have a high score should not go on a ventilator when there's a shortage. That to me is the utilitarian, the most ethical way to handle this. Is objective, and I think is what we should be doing.
What is your gut reaction on how many 80-year-olds survive? I know you're going to be 80.
I know that, and I've already made the decision I won't take up a ventilator. And there are 80-year-olds that make it, but not very many. Put it that way.
So
The ones who make it are the ones who are pretty active and vigorous and fairly healthy. They've got a reasonable chance. If there's ventilators, I would not oppose intubating an 80-year-old person who was very vigorous and active, didn't have a lot of comorbidity, and I had adequate ventilators. I would not intubate that person if that was the last ventilator I had, and I had a 28-year-old that needed a ventilator.
So Dennis, let me give you a hypothetical patient. They're DNR. They present to our emergency room, they're COVID positive. You don't want those patients there, I assume.
No.
Would we
No.
then?
One of the things that's very important to do in terms of COVID planning and management is deal with DNR issues up front, right at the beginning. I think that could be very, very helpful. But we should do that routinely. When I admit a patient to TLC, I've been doing this for 40 years. One of the first things I talk about is resuscitation, cardiac arrest. What should we do? What's the appropriate thing to do? And I think that's very important to do. It makes life a lot easier if things don't go well. And it's very important we do this COVID-19 because we can tie up precious resources for futile care, and we don't want to do that.
Is there a study going on of the futility? Is there a study going on right now of a futility index?
No, and I'm very frustrated that there isn't. I've asked around, and I'm not aware. They're collecting some data on ICU patients, but it's a study that CDC could have sent out for research nurses, and they could have collected. They could have said, if you collect these data on your patient, we'll give you $1,000 for your time. It's simple data, very objective data. You can get out in a retrospective review. Send it to a central repository, put it into a website. You can analyze the data. A good statistician could analyze that data in 3 or 4 hours, and you could have a model. This is not complicated type of analysis for research, and it's very, very, very straightforward.
Is ibuprofen okay for COVID-19 fever?
Is ibuprofen safe for COVID-19 fever? It's not been studied, so we don't know that with certainty, but the evidence that it's deleterious is pretty dubious. There's very little evidence. But most of the time, you don't need to use ibuprofen. I use ibuprofen mainly if the patient's got a lot of pain. Acetaminophen usually is adequate for fever. It works pretty well for fever. And ibuprofen, if they've got a significant amount of myalgias or pain with it, could be very helpful. So most COVID patients don't have a huge amount of pain, and so you don't have to use it in most patients.
What about the predisposition with a person who's on an ACE or an ARB?
I'm sorry?
A patient who's on an ACE or an ARB, what is the predisposition? What does that do to their risk?
There has been a lot of concern that maybe angiotensin converting enzyme inhibitors may be deleterious with COVID-19 simply because the receptor for COVID-19 on cells is the ACE2 receptor. But there's been very, very little data. And what we do, it's more of a theoretical concern, is that if a patient really needs an ACE inhibitor, they say have a cardiomyopathy and they're very fragile, we would not stop it. If on the other hand, we wouldn't start them. And there's actually a trial that's going to supposedly be undertaken to use ACE receptor blockers as a therapy for treatment of COVID-19, which makes sense logically. Whether it blocks it well enough so the virus can't get access, it's an interesting concept. Maybe it'll work. I think that's worthwhile studying. I'd like to see that in the arm of a multi-center trial.
Tina?
Do you feel like maybe this was circulating in January? We had some really sick people that tested
There's
negative.
pretty good evidence this was circulating in China probably way back in November.
So we could have possibly.
And we probably had it starting to circulate in the population in January. We know that we had cases in January.
Rich? You discussed the transmission of the virus via swallowing the virus. How is that transmission matter, and is stomach acid protective?
Is stomach acid protective against COVID-19? I don't think so. Reason I say that is COVID-19 can be recovered from rectal swabs or stool cultures about half the time. And in certain animals, it causes a GI illness. So I have to assume it's got considerable acid resistance.
I'm getting questions from people around the country. Please ask about prognostic indicators, especially CRP over 60 and troponin I.
I've not seen any data on them as prognostic indicators. The prognostic indicators have been really impressive. Are high LDHs, high interleukin or cytokine levels, high D-dimer levels have a bad prognosis. Most of those patients that have those tests, you look at the patients, they're not doing very well. They're on 2 pressors. They're on an FiO2 of 90%. They've got very abnormal liver function. They're thrombocytopenic. They're in multi-organ failure. And you don't need a marker to tell you the patient's not doing very well. But those patients do very poorly.
With the numbers coming out now on how the epidemic is increasing in Wisconsin, do you think that we have flattened the curve, or do you think we're going to be inundated?
I'm convinced we're probably flattening the curve, but we could still be inundated. If you didn't flatten the curve, you're really going to be inundated. If you flatten the curve, you may be mildly inundated, but you can handle it. The goal is to be able to handle it. That it's what you're doing is tamping things down enough so that you spread out the number of infections so your system can handle them while it can handle them. If they all come at once and you can't handle them, like New York City, that's where it's devastating. I don't know if you read, the New York Times had an article yesterday about healthcare workers in New York City. I mean, that's a nightmare. I mean, it's just the only way to describe it is simply absolutely a nightmare.
When do you foresee the peak in Madison area or Wisconsin, and how
I'm
long?
also reluctant to say when the peak comes because you can't make that assessment until you start to have a significant rise. And you've got at least 4 or 5 days to have a plot and see what the slope is, what it looks like.
Okay.
And I think it's very, very hard to say what the peak is. I mean, for instance, in New York City, they were saying they thought the peak was going to be April 3rd. I'm not so sure they can make that assumption. You'll only know the peak is coming when you have 2 or 3 days in a row where you have fewer patients than you had the previous days, and then it's starting to come back down. And it's very complicated business trying to predict peaks.
What do you see as life in July and beyond that?
I think there's a fair chance that things will have settled down a lot by July. Things will be much better.
Will we go back to large group gatherings?
Oh yeah, I would think so. Once we're seeing very few cases, there's no reason not to. Yeah, absolutely. We've got to move on with the world. We can't be hunkered down forever. We can't stay hunkered down for 6 months or a year. That's not realistic. There won't be enough food in the supermarket. So, and companies and droves will be going belly up.
So I've heard for that to happen, though, we have to have like herd immunity to the tune of like 60%.
Well, it's not totally clear how much herd immunity. We don't know that, but that's the problem. Because herd immunity is variable for different pathogens. certainly you need a high level of herd immunity for things like measles. With measles, if you're not 85 or 90%, you're going to have measles. That's what we're seeing in parts of California on that. But for a lot of other pathogens, it doesn't seem to be that high. SARS wasn't that high at all. SARS was controlled, and the interesting thing, SARS had one thing that was very different from COVID-19. There was almost no subclinical disease. Everybody who got SARS virus got sick. They screened large numbers of exposed healthcare workers who hadn't gotten sick, large numbers of patients who were exposed, family members. If they didn't get sick, they weren't seropositive.
Is there any crossover with immunity to SARS?
Now that's a very good question. I would have to assume the answer is almost certainly there is, but not all that many people got SARS. Only about, something in the order of, I want to say, 100,000 people or something like that. It's a drop in the bucket compared to this far smaller number, much smaller number.
Would you like to revisit this topic in 2 months?
I think in 2 months we will be so COVIDed out that nobody wants to even think about COVID.
I'm going to ask Rich if there's any other key questions you can see being a clinician.
Is there any sense in letting COVID ID health workers be restricted to working with COVID ID 19 patients?
Oh, absolutely, absolutely. I mean, if I were COVID-19, I'd get on an airplane, go to New York City, and help friends there, because they're looking for volunteers to come in, but I'm committed to take care of patients here. And if they somehow told me that I couldn't work on the COVID unit because I'm too old, that's what I would do. So.
And we've got a long list of.
Keep going.
Okay. If healthcare workers are screening patients in a triage tent, do they also be in self-quarantine due to asymptomatic carriers?
If they're treating COVID patients?
If they're screening patients in a drive-through tent for testing, do they have to be quarantined?
I think if are they drawing bloods from people?
No.
No, but they're doing.
No, if they're not drawing blood, they're doing swabs.
Swabs.
Yeah.
With PAPRs.
If they're using PAPRs, I would say probably not.
What about face shield and mask?
What?
What about with face shield, mask, and gown?
We're starting to have gradations of difference, but there's pretty much good consensus for people who are taking care of COVID patients in a hospital. They ought to stay in home quarantine when they go home. They should not be going out, and if possible, it'd be better if they're separated from their family. When you consider the high rate of infection of healthcare workers, it's not an appropriate recommendation. We're looking at gradations of risk. We're a no-risk society. Everybody wants no risk.
There's a question about whether we should be doing child well visits for children under 18 months in order to provide their vaccine.
Whether we should do
vaccines.
Well, child care under 18 months for vaccines for children at clinics.
You have to see those kids in person to give them a vaccine, and should they?
Well, I think that I think you should be doing that. I think kids should be getting their vaccines. That's a good question. I'm not a pediatrician. I hadn't even thought about that, but that's a very good question.
That's what we're doing.
I think it's possible to use enough barriers that the risk is low. It's low to the family, the mother, and the child who come in, and I think that kids should get their vaccines. If this was only going to last another couple of weeks, then I could say we can wait a couple of weeks. But if we're not talking about another 4 to 6 or 8 weeks, that's another story. I don't know, what are you doing right now?
At Prairie Clinic, we're having kids under 18 months come in on.
I think that's
schedule.
reasonable. The one thing that we know, COVID-19 appears to be very benign in healthy children. Almost all the children, small children who've been infected, have had congenital heart disease. Interestingly, that's what they found in China. They've had very, very, very little infection, even though there was a death of a newborn reported. When you've got huge numbers of infection. You're going to have a kid who's probably vulnerable.
So if we're bringing somebody in for surgery and it's non-emergent, we should be testing them or making sure they're clean?
Well, I can't tell you what to do. I can
If
just,
we get in-house testing.
if you have in-house testing, yeah, I would test them. Another month, and we're drowning in it, and we have the capacity. I think we should be screening every patient who comes into the hospital.
Like non-
We have time for 2 more questions. So Rich?
Should any precaution be taken when you're hiking outdoors or doing outdoor activities with children?
Make sure your children don't get in dangerous situations, but not very worried about COVID.
Is there an initiative to identify those HCPs with immunity to allow them to cohort for COVID-19 patient care?
So are we looking to, go ahead, Dr. Barkley.
Is there, for people who are immune to COVID in healthcare workers, is there any initiative to use them in the epidemic?
They are using them in Europe and to a lesser degree in New York City, people who have been infected, but there aren't very many because they feel compelled to keep them out of the hospital so they're not contagious. But I would see no reason a well healthcare worker could not go and take care of COVID-19 patients. The biggest concern is they'll infect other healthcare workers who are not yet infected. That would be the limiting factor. So it'd be ideal to wait until they're no longer contagious.
Well, we're at the top of the hour. I truly appreciate Dr. Maki coming in. We could probably talk about this for another 6 hours. So with that, I will, again, thank Dr. Barkley for organizing, Lisa Perrell, who did a fabulous job along with Information Services. Thank you, Dr. Maki.
Thank you very much.